Welcome. My name is Michael Potter, and I co-chair the National Colorectal Cancer Roundtable's Professional Education and Practice Implementation Task Group, along with my colleague, Dory Lane. Thank you, everyone, for joining. We've had a lot of interest in this topic and appreciate your time. We're grateful to have so many health plan participants in the audience today. The purpose of today's webinar is to introduce you to the Roundtable's latest resource, the Colorectal Cancer Screening Best Practices Handbook for Health Plans, which is designed to provide health plans with advice on the design and delivery of effective colorectal cancer screening programs. In our strategic planning process relating to 80% by 2018, health plans were identified as a key partner we needed to engage in the effort. We recognize that health plans play a key role in achieving increased colorectal cancer screening, and many are motivated to prioritize efforts to increase screening rates among their members. But there has been a void of evidence and guidance on proven strategies to increase rates for health plans. Noting this gap, the Roundtable's Professional Education and Practice Implementation Task Group developed the vision for this handbook, and it took shape thanks to the help and input of an advisory group made up of health plan medical directors and quality improvement leaders. We're confident the handbook provides a state-of-the-art compilation of best practices, case studies, templates, and tools that will provide plans with the roadmap they need to better engage providers and activate members to get screened. So today's webinar will provide participants with an introduction to the best practices, case studies, and templates and tools found within the handbook, and offer a deeper dive into the exemplary practices of one of the profiled health plans. So we will first hear from Tamara O'Shaughnessy, Managing Director for Research at the Q&A Group and lead author of the handbook, who will walk us through the rationale for and development of the resource, as well as best practices, and provide some examples of how they have been implemented at high-performing health plans. We will then hear from Dr. Anshul Dixit, Medical Director at Wellmark Blue Cross and Blue Shield, who will share how Wellmark is implementing some of these best practices to increase screening among their members. I'd like to share a few housekeeping items before we get started. First, we're recording today's webinar, and the replay and speaker slides will be shared with all of you within a few days. Please feel free to share them with your colleagues that were not able to join us today. Second, because of the large number of participants, you'll be muted on today's webinar. But having said that, we encourage you to submit questions through the webinar Q&A function. We will have time for questions after the presentations, and we'll answer as many as we can, and we'll be emailing responses to any questions we don't have time to get to. You can also email us additional questions afterwards. And finally, we are always trying to improve our webinars, so please help us in evaluating the webinar at the end. You will soon be receiving an email with a survey link. Please complete it. It will just take a few minutes. We're always happy to get advice and your constructive suggestions, and we take it all very seriously. So with that, I am pleased to turn over the webinar to Tamara, who will begin by providing an overview of how the handbook was developed.
Okay, thank you very much. So I'm going to be taking you through some of the components of the handbook, including how it came about. So just by way of background, this all really got started when the Roundtable started gathering information from health plans in order to just identify what was being done by plans that might be viewed as innovative or exemplary. So the first step in this process was really to gather that information via a survey. And the results from that survey were assessed kind of on two levels. Number one, trying to identify health plans that had achieved high screening rates for their members, so numbers in the 70s or even the 80s in terms of screening rates already achieved. And then secondly, identifying health plans that maybe had done something innovative. Maybe they were piloting a program or a strategy that would reach an underserved or challenging population. So they identified a number of these sort of high-achieving plans, and we contacted them to determine if they'd be willing to share those stories with us so that we could develop this resource to share with other plans that might be seeking to do something similar. The process of gathering the information was done by conducting in-depth telephone interviews with representatives from these plans. We spoke with quality managers, chief medical officers, program managers, and others who were responsible for quality improvement. We, in the end, identified 12 health plans that were going to be included as essentially case studies in this handbook. I do want to say these aren't necessarily the 12 highest achieving plans that are out there. We know there are many other plans that are also doing great things. These happen to be the ones that we found to be good examples of strategies that we had heard about and wanted to feature. So we definitely want to thank them for their participation in this process and sharing all the information that they did. One of the things we wanted to make sure we focused on in the handbook was understanding how to encourage other health plans to focus on colorectal cancer screening. Certainly it requires some staffing and some resources to set aside for something like this, and we wanted to understand what it was that motivated these high-performing plans to focus on this issue. What we found is, of course, first and foremost, improving member health was a very important motivator for these plans. But also part and parcel with that were the importance of business considerations, essentially. Improving HEDIS scores was high on the list for these plans. Improving their Medicare STARS ratings and, of course, the associated bonus payments were important motivators. Similarly, using those achievements and improvements in their ratings were important motivators to be able to market themselves and to essentially promote their quality to consumers on the individual market. In some states, state-level quality objectives were also an important issue to consider. And then, of course, cost reduction plays into this. The cost to treat late-stage colorectal cancer can be extremely high, and we know that screening early in the process can either eliminate those cancers or catch them at a time when they're a lot less expensive to treat. Throughout the handbook, as well as periodically in this presentation, we're including some quotes from the participating plans that shared their information with us. And in this particular instance, you see a quote here from a respondent at Gateway Health who's just reiterating this point that, even if you're not tied into a bonus program like the CMS STARS program, cost reduction is something that every health plan can get behind, and that impacts all of those decisions. Some of the achievements that the plans in this handbook have gotten to 80% screening rates for several of the plans that we're featuring. Many have seen significant year-over-year screening rate improvements. Even if they haven't yet reached 80%, they're showing that progress. We've seen reductions in disparities between subpopulations. And then, of course, cost savings, fewer cancer episodes, and reductions in late-stage cancers. There's a quote here from someone at Kaiser Permanente indicating, again, it's more effective to prevent cancer than it is to treat it, and, of course, more effective to treat it early rather than late. One thing I do want to note is that a few of the health plans that we are featuring in the handbook have done fairly extensive ROI analyses of their programs. Unfortunately, because it's a very proprietary process and their costs, many of them, of course, keep that information very close, we weren't able to provide those details in the handbook, but they did indicate to us that in each of the cases where they had done that analysis, the investments that they've made in colorectal cancer screening programs have certainly shown dividends and saved them money. All right, so the content of the guide is listed here. You can see that we've got a variety of pieces of information ranging from contextual information via case studies, as well as information from the literature, things that have been published out there, some excerpts from what the Roundtable has provided in the past that are most relevant to health plans in particular, and then also some samples and templates. Several of the health plans that we're featuring were generous enough to share materials that they have used with their members, outreach materials, examples of calling, outbound call scripts, incentive programs, et cetera. So we really tried to make the handbook something that was applicable immediately and has content in it that can be kind of modified and taken to the field right away if possible. For this particular, the rest of this session here, we're going to be focusing on the case studies. And each case study, in this case, is showcasing a particular best practice. We identified 10 best practices that we summarized in the handbook. And one thing to note is that although in this presentation we're only focusing on one best practice per plan, really the plans that are most effective are certainly employing more than one of these best practices. In many cases, they're doing 5 or 6 of these at the same time, really trying to tackle the issue from several different perspectives, and that only makes them more effective. Okay, so the first best practice I want to touch on is employing a multifaceted population health approach. And for this particular one, we chose to highlight Kaiser Permanente. Many of you may be familiar with them being a very integrated system and one that makes very effective use of their data resources to manage the health of their members. Kaiser was very early to this issue, and so they've been able to develop a systematic approach to screening that they've modified over the years, over more than 10 years that they've been kind of refining their approach. And what they have today is this very systematic approach to screening that starts out with advance letters that they send to members who they've identified as being due for screening, followed by automatic mailing of fit kits, so their members don't have to go see a physician first. They can just be automatically sent these kits. They receive a phone call reminder from a physician. It's not necessarily their physician, but it is a Kaiser physician who contacts them and lets them know that they should be returning this kit and the importance of the screening. And then if they still don't respond, they do receive a personal phone call. So in addition to that very systematic approach, the other thing that is notable about Kaiser's approach to this issue is they have this system-wide expectation that quality is everyone's responsibility. And the way that that manifests itself is that really anybody who is interacting with a member has the ability to deliver a screening reminder, to pull up that individual's record and say, okay, maybe you're calling today to make an appointment with a doctor or request something else, but hey, we've noticed that you're due for your colorectal cancer screening. And that person then has an ability and authorization to go ahead and mail them a fit kit. So this approach has yielded some wonderful dividends for them. Their screening rates have improved all the way up to more than 80% today. The second best practice we're looking at is making effective use of data. And that's both in terms of working with members and working with provider networks. South Country Health Alliance is a health plan we wanted to feature for this best practice because what they've done is used their data resources to really customize their pay-for-performance program. Many health plans do have a pay-for-performance program, but in this case, what they did is negotiated with individual clinics in their network. And taking a look at the local population for those clinics, the screening rates and the disparities that were unique to each location, and essentially negotiated different target rates with each clinic. This was very appreciated by the providers at those clinics because they had the opportunity to take a careful look at their data and provide input on how they were going to achieve the goals that they themselves were helping to set. The health plan supports these clinics. There's a great deal of transparency in terms of performance data. And additionally, they provide very careful assessments in terms of screening rates. In some cases, health plans only provide claims data, for example. South Country actually provides a blended rate based on both claims data and medical record review, which is a challenging thing to do given the complexities of colorectal cancer screening in terms of capturing that, because there's so many types of screening that can be done and can count. But the clinics ultimately appreciate that kind of detail, and it pays off. As you can see, their screening rates here at 66% and 77%, depending on the audience. The plan actually serves primarily special needs members, and so those screening rates are particularly impressive, given that it is a challenging population. All right, the third best practice is promoting test choice. The round table, of course, has some wonderful research that shows the importance of promoting test choice and the fact that it increases consumers' acceptance of screening if they are offered something other than just colonoscopy. Gateway Health is a plan that adopted this approach fairly early on, recognizing that offering a choice only increases adoption of screening, and that really screening rates will top out at some point if consumers are not offered a choice, because ultimately there will always be some who will refuse colonoscopy. So this was really an opportunity to kind of break that ceiling and get over those who are resistant to one particular type of test. So what Gateway Health does is they reach out to members, again, who've identified in their database as due for screening. And their outreach approach is begun with an interactive voice response system. Through that system, members are receiving education about screening options. So at that point, they can choose to go ahead and order a FIT test. They can transfer and speak with a plan representative to discuss different screening options. Or they can just make an appointment with their physician at that time and then have that conversation then about which choice is right for them from a test perspective. Additionally, through this process, members receive education about what a positive FIT test actually means, so that we don't have individuals who feel that a positive FIT test is the end of the story, but rather they're prepared so they know that if that test comes back positive, they're going to need to take the next step and have a colonoscopy. As a result of this approach, Gateway's seen their screening rates rise by 15 percentage points in 5 years. Fourth best practice we have is using direct member outreach in partnership with providers. And Care is a health plan in Texas that we wanted to feature here because they've done an excellent job of working very closely with their provider network in order to kind of share the process of coordinating and reaching out to their members to get them screened. They have a Medicare Advantage plan, and they contacted their providers with an idea to set up some sort of standing orders so that everyone in their, every member of their health plan could be contacted directly by Care and receive stool test kits. This was an idea that their providers agreed to. Almost everyone did agree and liked the idea that Care would take the responsibility to do this for them. It would ease the burden on them. And then the health plan really supports the whole process throughout the kind of the continuum of contact. Not only do they send out identify the members who are due and send out the kits, but they also do individual personal phone calls to remind members to send back their kits. And they also will personally contact the primary care providers if they receive a notice back that a kit test or a test was positive. They do have a healthcare concierge program, and they will call members if they don't complete the screenings and provide other types of support as well. They may help arrange for appointments, for follow-ups. They will even do things like help arrange transportation for those who need to get to and from a colonoscopy. All these efforts resulted in a screening rate of 77% for their plan as of 2014. The fifth best practice is addressing cost-related barriers with policy change and education. Cigna has done a lot of different things to raise the screening rates in their populations. This is just one of the things that they've done very well. And it was in part as a result of feedback that they received from members when they were communicating about the importance of colorectal cancer screening. One of the most common questions they received was, what is this going to cost? And so they took steps to try to minimize those cost-related barriers. They're now fully covering all U.S. Preventative Services Task Force approved screening options, including some of the newer tests that are out there, like CT colonography. They've also removed as many cost-sharing barriers as they possibly can. For example, colonoscopies that follow a positive FIT test have no cost-sharing whatsoever for members. These are steps they've taken that are really above and beyond ACA-mandated requirements. Additionally, when they're communicating to members about the importance of colorectal cancer screening, they're really emphasizing that this is 100% covered. So, they recognize that any level of cost is going to be something that members will latch onto if it's a test that they want to avoid. And this is one of those tests that often falls into that category. So they definitely communicate about that when they reach out to members. And again, these have resulted in some significant increases, 24% increase in screening rates just in 1 year here. Okay, number 6, incorporating colorectal cancer screening into provider incentive programs. This is something that almost all of the health plans we're profiling are doing, in addition to other strategies. Blue Cross Blue Shield of Massachusetts is the one we wanted to highlight here. They have an alternative quality contracting program, which is essentially a risk-sharing alternative for their providers. They have 64 quality measures that are incentivized for their providers. And the way they've structured their incentive program is that providers, of course, receive an incentive if they reach a particular number, a goal for their performance, but they also receive incentives for making progress towards those goals from 1 year to the next. So if they have shown improvement, they essentially also receive a portion of the anticipated incentive. The other thing they do for their providers, which they've said have been very effective, is to provide their provider groups with data on how they compare. So they have 19 different provider groups, part of these alternative quality contracts, and they provide blinded data so that each provider group can compare themselves to others to see how they are doing. And this has resulted in a very impressive screening rate of 84%. Best practice number 7 is identifying opportunities to make screening an easier choice for members. Immunity Health Plan of Washington has done something called the MORE program. And what this is an incentive program for members that encourages them to close gaps in their care, including colorectal cancer screening. So they have 6 targeted areas, And members are just automatically put into this program if the data shows that they have a gap in care. Depending on their previously stated preferences, members in this program will receive interactive voice response calls or text messages or mailings with reminders to schedule screenings in one of a number of different areas. If they complete each of the screenings, they receive a $15 gift card as an incentive. So that's one way that they're just removing barriers. Another way is at the moment they're running a pilot program that, again, like what we talked about with the Kaiser program, just proactively mails fit kits to Medicare members. And again, this is something where they're just removing a barrier, the barrier being having to see a primary care physician first. Once that's gone, this thing can just go out automatically, and they've seen some impressive improvements in their screening rates. Best practice number 8 is focusing on screening disparities to reach 80%. Blue Cross Blue Shield in Minnesota went through a process where they dramatically simplified their provider incentive program. So they now focus on only 10 performance measures and areas that they identified as being high impact. Diabetes, asthma, ER visits, and colorectal cancer screening being one of them. The other important thing they did here was instead of having those incentive programs based on the entire member population, they focused them exclusively on the non-Caucasian population. And what this did was really kind of signal to their providers how important they felt that population was, and also help them to really narrow that gap in disparities. Because again, there would really be no way for many of these plans to reach the 80% mark without really reducing disparity gaps in their membership. Best practice number 9, celebrating success and sharing best practices. Health Partners has a couple of programs that we wanted to highlight, the Partners in Quality program, as well as the Preventative Care Recognition Award. These are programs that provide recognition to providers, pharmacy groups, and other partners that are really achieving sustainable improvements in preventive screening care. They honor these they honor these partners in different ways. One is an annual awards dinner. They also publish something to honor their successes. And this is something that we've seen other health plans do as well in different ways, not just to sort of highlight their achievements, but also to provide a forum for sharing information. We've heard that provider groups are very willing to share what they've done with their peers and to talk about what they've learned from different pilot processes that they've put in place. So Health Partners and other health plans do webinars, dinner meetings, newsletters, and things like that to share the successes of their provider groups. And here we've seen their screening rates reach 82%. And the last best practice we wanted to talk about is just the process of piloting and refining the approach. Many of the health plans that we spoke with through this process have used the approach of piloting a new idea with a small, narrowly defined group, either a geographic group or a particular ethnic group, or rural versus urban, in order to sort of do a proof of concept test and then determine whether something worked and roll it out to the larger membership later. So these are just some of the examples here. You can read more about them in the handbook, but these are some examples of them focusing on rural members, unattributed members who don't have a primary care provider, Latino members, et cetera. And they've done, each of these plans has done a great job of revising what they do based on the feedback from these pilot programs and then making changes. The last few slides here are some examples of the materials that are available in the appendix of the handbook. I mentioned earlier that there are a variety of samples that the health plans have provided to us. materials such as education that they send out both to providers and to members. We have an IVR call script that was used by one plan, as well as mailings and other educational material. All right, so thank you very much. That's the introduction to the health plan. I hope that you all take, to the handbook, I hope you all take a close look at that now that it has been officially released. And now I will hand this over to Dr. Dixit to continue on with his case study.
Thank you, Tamara. It's a delight to be here and to have an opportunity to present our work. It's even more wonderful to be in the company of these rockstar health plans who have been very generous with their time and have shared best practices. Now imagine a scenario where health plans across the country were to adopt some of these practices. Or better still, if they were to come up with even more innovative approaches to colorectal cancer screening. 80 by 80 would be within our reach. In my role as medical director at Wellmark Blue Cross and Blue Shield, I get to work with some really passionate and knowledgeable stakeholders who are collectively working to improve the health of Iowans and South Dakotans. Among them are the Iowa Cancer Consortium, the colorectal cancer roundtables in the states of Iowa and South Dakota, the Cancer Society, and our accountable care organizations. So this is truly a collaborative work. The health plan here is merely a facilitator. While preparing for this talk, I was reminded of the year 2002. I was a freshly minted internist. The charts were paper-based back then. Most of the colorectal cancer screening options were fairly invasive, with the exception of fecal occult blood testing. Population health was a term that had just been coined. Fee-for-service was the predominant reimbursement mechanism, and practice-level data was hard to come by. Now fast forward to 2017, electronic medical records are fairly prevalent. There's an array of options as far as colorectal cancer screenings go. The fee-for-service models are being replaced by value-based purchasing, and we are awash in data. That begs the question, we are certainly awash in data, but are we awash in value? And as a health plan, we are trying to move the needle to get from data to value. Now here's a slide that shows there's a snapshot for our accountable care organizations. Our health plan serves 2 million members in Iowa and South Dakota. Our main lines of business are HMO products, PPO products, Medicare supplemental plans, and for the very first time in 2017, we have products on exchanges in the individual market. We began with our first accountable care organization back in 2012. As of 2017, we now have 16 accountable care organizations. About a third of our enrolled population is now covered with some form of an ACO contract. In 2011, our organization set an audacious goal. The goal was bringing our healthcare trend in line with the consumer price index. This would mean reducing the total cost of care by a multi-pronged approach. We had to pay close attention to the unit costs while encouraging use of high-quality, cost-effective services. We knew we had to carefully monitor the frequency of services being utilized and also address advances in technology through appropriately using these technologies in our population. Now this is our population health slide, covers our entire book of business. Our Chief Medical Officer, Dr. Jim Gutschall, jokingly says it is possible to teach an entire course on population health based on just this one slide. this slide is very valuable to the accountable care organizations in helping them understand their attributed population. At the top, we have non-users, the healthy group of individuals, and those with acute or minor conditions. Collectively, these three groups form about 73% of our entire book of business, and they incur about 40% of the costs. Costs begin to go up with the development of chronic conditions. With the development of a single chronic condition, the per member per month costs are $430, which is slightly above the average for our entire book of business. A remarkable thing happens during the transition from single chronic to double chronic. The per member per month costs go up threefold. During the transition from double chronic to triple chronic, again, the costs triple. The folks with malignancy form a small proportion of our entire population. However, these are individuals who incur the second highest costs in terms of per member per month, and they are the focus of our colorectal cancer screening efforts. So what does this mean from the standpoint of colorectal cancer prevention? One, we have to get non-users to interact with the system more, to use the services that can prevent things like colorectal cancer from happening. And we have to keep the folks in the healthy group healthy for a longer period of time by increasing adoption of screening services. And finally, we have to manage the chronic conditions well by sharing actionable data with our provider partners. Now, here are some of the requirements for transformation of the current care paradigm. The providers have data, insurance carriers have data. The carriers have to share data with providers that is truly usable. Could be in the form of gap reports or completion reports on their attributed population. Transforming the current care processes also involves moving away from a captain of the ship philosophy to more of a collaborative, inclusive approach, an approach that values the skills of different team members, where every team member has shared responsibility for improving the adoption screening services. Our providers have implemented new workflows such as rooming procedures, navigators, and call campaigns. These were quite foreign when I began practice back in 2002. However, now they are the norm within our accountable care organizations. New incentives such as value-based payments are taking hold. Our health plan also recognizes clinician champions and best practices within our accountable care organizations. And these best practices are profiled in our provider-facing publications to encourage other providers to think of adopting similar processes in their practices. In addition to data and new workflows, we also need an expertise in change management. For instance, as a health plan, we found that the health maintenance tab in electronic health records was not being fully utilized. We discussed this with our accountable care organization partners, and they saw value in supplementing the claims data with provider-level data that's available through electronic health records. A new workflow was created, and change was implemented. Clinician leadership is key. The docs influence other docs, they teach other docs, and they help in the diffusion of best practices throughout our network. Now, this slide is our famous rainbow slide. The Value Index Score, VIS for short, is a proprietary tool of 3M, and it helps us calculate the performance calculate a score that reflects the performance of our accountable care organizations. It measures the performance of our ACOs in 6 domains across 14 different measures, and colorectal cancer screening is one of the measures within the primary and secondary prevention domain. Now, the VIS is a complex calculation, and it is a composite of the accountable care organization's performance on 14 measures. Our approach has been to tie financial incentives to our participating ACOs that are based on their performance on the value index score that we saw on the previous slide, with the colorectal cancer screening being one measure within the value index score. We share a dashboard of indicators with our accountable care organizations. The dashboard is updated monthly, and it contains information on their attributed membership as well as their performance on quality measures. We conduct monthly conference calls with our ACO leadership to have a continuous conversation on how, as a health plan, we can support them with member-level data and analytics. Our care gap reports to the ACOs show them their attributed and eligible population and completion rates of various screening tests. Some of our accountable care organizations use our outreach to members in the form of birthday cards or reminder calls to members who have become newly eligible for screening. Others have chosen to do these outreach campaigns on their own. Now, when we call members, an interesting thing happens. We did a study some time ago calling half of our members with half of our members saying that we are calling from the health plan and we'd like to remind you that it's time for your screening. Among such members who received calls saying we were calling from the health plan, the uptick in their screening rates was 1%. The other half was called saying that we are calling from your health plan on behalf of your primary care physician. And in such members, the uptick in screening rates was to the order of 4%. The clear difference when we leverage the strength of the primary care physician relationship with the member. Now, this is a slide that captures the performance of accountable care organizations over time. Each line on this slide represents an accountable care organization and how their colorectal cancer screening rates have fared over time. On the vertical axis is the percentage of eligible members who had a screening test done in that particular year. Those with previous colectomy, a diagnosis of colon cancer, and those in hospice were excluded. The accountable care organization in orange began at the bottom of the heap with really low rates of colorectal cancer screening. However, due to a strong buy-in with their leadership, sustained efforts and focus, their screening rates continue to improve. For comparison, the accountable care organization in blue had some ups and downs. In 2014, they began looking at Medicaid measures, and they stopped looking at their value index score. As a result, their performance on the colorectal cancer screening metric declined. Now, this slide has prompted several fascinating discussions among our ACOs who receive performance, blinded performance on everybody else, and who receive unblinded performance on their own membership. As with claims data, the data in this slide only go back 5 years, and claims data only work for members who have been continuously enrolled, and claims data must be supplemented with provider-level electronic health record data. we started off with our ACOs in 2012. By 2013, the adoption rate, the completion rates of colorectal cancer screening were essentially unchanged in our ACO population and our non-ACO population. We began to see some divergence after 2 years with an obvious increase in screening rates among the accountable care organization population. Encouraged by these results, we are now sharing the same data with our non-ACO providers that we have previously shared with our accountable care organizations. In a couple of years, I would love to come back to this forum and report the results with our non-ACO providers. So it just goes to show that improvements in an ACO population are driving improvements in our non-ACO providers as well. This next slide here shows population health works. Among our accountable care organizations for claims going back 10 years, 60% of eligible members had had a colonoscopy. For comparison, those in non-ACO arrangements only got up to 40%, about 40% in terms of colonoscopies. Now, of course, this data is claims data. It includes colonoscopies only. It does not include FIT testing, stool DNA, or sigmoidoscopies, and it does not include procedures that the member may have had with other payers. So it's likely that the numbers are higher, and the providers will be able to supplement this data with data from their electronic health records in their journey towards 80 by 18. So key lessons learned in our journey towards improving colorectal cancer screening rates. First and foremost, as a health plan, we must respect the relationship between the member and the primary care physician. We must support, nurture, and enhance that relationship because members have a high degree of trust in the recommendations of their primary care physician. When providers share responsibility for improving screening rates with the health plan, and when they share responsibility for improving screening rates within their office with other members of the care team, this results in happier providers, satisfied members, and a reduction in the total cost of care. Equipping our ACOs with timely data, providing incentives, providing them information on their eligible population, and providing them granular reports in terms of completion rates drives quality improvement. Educating providers on costly unnecessary services such as the use of general anesthesia for low-risk procedures, and communicating with providers in advance of any change in medical policy has also led to satisfied providers and improvement in quality. With that, I will now hand this back to Dr. Potter. Thank you for the opportunity, and I look forward to your questions.
Well, thank you both. That was just fantastic. And now we'd like to take some time for questions. We have about 10 or 11 minutes until the top of the hour, so we'll try to get through as many as we can. And I just want to start out by saying a lot of the questions were specific to individual programs, and I just want to encourage everyone to look closely at the case studies. And there may be an opportunity for you to communicate directly with some of the people who run those programs. But I'm going to go through some of the questions now. And the first question that I saw here that I thought was particularly relevant was, with all of these FIT outreach programs, what can the speaker say about how you balance the idea of sending out a lot of FIT tips to everyone who hasn't been screened versus trying to figure out maybe who might have a family history or have high risk and maybe need a colonoscopy instead. Just wondering if either of you have experience addressing that issue in these large outreach programs.
So in our, go ahead, I'm sorry.
I was just going to say, in the interviews that I conducted, some of the health plans that had information, if they had access to information about the risk factors like family history and whatnot, that they were able to exclude those individuals from their mass mailing programs.
Dr. Dixit, did you want to add anything?
In our communities, we have a gastroenterologist who's a passionate champion and wants to increase screening rates by adoption of FIT testing. Got a grant, implemented a call campaign, got very few folks who chose the test. We kept wondering why that was. Eventually, he understood that the members value their relationship with the primary care physicians much more than they do with their specialist or with their health plan. So the call campaign was resurrected, and this time he had them, he had the primary care physicians, navigators call the patients with astounding results. So with FIT testing, leveraging that primary care physician relationship in our membership has been key. I don't know if it speaks clearly to the exclusion of high-risk members from the FIT test that your question alluded to, but I thought I'd share this experience because that was very encouraging within our planned population.
Right. Well, that's great. I think that both of those are important points. Another point that came up in the questioning was, which is equally important, is follow-up of abnormal tests. And with all the attention on increasing screening rates, are we worrying that we'll screen a bunch of people who then, without enough attention to follow-up? And what are the plans that you spoke to trying to do to make sure that people who screen positive are navigated to appropriate care in a prompt and effective way?
Well, one thing I certainly heard is that you know, the level of follow-up after a positive FIT test certainly varied depending on the resources of the health plan and the extent to which they could have individuals actually place follow-up calls and whatnot. Typically, that would be handed off to a primary care provider. But in some cases, you know, such as the Care and Care example, that they did have certainly a much more hands-on approach with an RN placing calls to those who had a positive FIT test to really kind of hold their hand, make sure that they continued on to get their colonoscopy done, and making sure that the resources were available so that they could do that. But certainly that's something that varies from plan to plan.
Okay. Another question that came up was, people are really appreciating this importance of the primary care relationship, but many unscreened patients have not been into the practice or may not have a primary care doctor clearly designated. So how is it that where do those test results go, and how does that person get navigated into primary care? You know, the double question. How do you arrange to have someone screened when they don't have a primary care doctor, and how do you arrange follow-up if the test is abnormal if they don't have a primary care doctor?
That is precisely the challenge. If you remember that population health slide, at the very top were the healthy folks. About 15% of the population who have no reason to see a primary care physician, who feel well, who don't have any symptoms, and how we go about engaging them. How do we go about getting them to use the services that are truly of value. We have member-facing publications in which we try to hit these issues about age-appropriate screenings, about reminders, about proactive phone calls, call campaigns. But I acknowledge this is a challenge that we are still trying to work through.
One thing that we did hear about through Health Partners is a pilot program that they're using to actually reach out to unattributed members. So if they don't have a primary care provider, they're receiving mailed fit kits and using that actually as sort of an entree or a way to encourage them to select a primary care provider. And I can't recall off the top of my head, but it may be that they're suggesting or assigning a primary care provider to those who are unattributed and who do respond to the FIT mailing. I know some of these questions are very specific to what an individual plan is doing. So it may be that we can follow up with those who provided the information at the plans and get some of those questions answered if they are a little bit more detailed in that sense.
There was a specific question about Wellmark Blue Cross Blue Shield and whether you distribute the care gap reports to providers. Is it through some web portal or through physical files? Maybe that's a detailed question that could be answered later, but it may be relevant to others.
So thank you for the question. And our accountable care organizations do receive completion reports, care gap reports, opportunity reports on their own attributed population. They receive aggregate blinded information with respect to other accountable care organizations. As far as the further specifics and the granularity of the information, I'll have to get back in a different setting.
There's a question about some of the cost of some of these interventions. These programs seem like they are could be high. For example, there was the mention of Care and Cares providing transportation to patients when they are in need of care for the colonoscopy following the colonoscopy procedure or other problems like that. I'm wondering if you can speak to the issue of how these plans assess the costs of some of these things that sound on the face of it to be expensive. That would be maybe something, Tamara, maybe you got some sort of flavor for that when you were speaking to the plans.
You know, it's funny because it recalls one of the Kaiser Permanente individuals who shared with us a case from Hawaii where they actually will pay for the cost of a helicopter flight from one of the other islands to, I believe, Honolulu is where they do all of the colonoscopies. So I'm not sure how they calculate the ROI on a helicopter flight, but clearly they feel it's worthwhile. In the case of Care and Care, I don't actually know if they are directly paying for the cost of transportation or if they're just trying to navigate patients who need transportation assistance to, various public options for medical transportation. That's kind of a level of detail that we didn't get into in the interviews.
Right. Well, we're almost to the top of the hour. There are a lot of questions we did not get to, in particular some of the questions about share of cost and so forth and how that works, waiving payments for various findings and how plans make that work for them. Get people as soon as possible afterward with some email answers, and please do feel free to be in touch. I would like to, we are at the end of our time, and we'd like to share a big thank you to everyone who put together the plan this handbook for us. And we like to share our sincere appreciation to the plans that volunteered to share their stories. And we'd like to thank Tamara O'Shaughnessy and Dr. Anshul Dixit, Greg Walker, Matt Flory, the NCCRT Roundtable, and the many partners that contributed to the handbook. And thank you also to the CDC for providing funding to make this webinar possible. And I'm just trying to scroll through these things. So please do check the NCCRT.org website and connect with us on social media to find information about upcoming webinars and news. And for more information, please email us. We'll send a follow-up email to all of you with a link to the handbook and the webinar replay. Thank you all for joining us today, and I hope you have a wonderful afternoon.